Okay, so good morning, everybody. My name's Caroline Miller. I'm a consultant in chemical pathology, metabolic medicine up in Scotland. You can find me on the inner circle under Caroline Kirkland, and I was a previous TSD client before I started to do some work for Alex. So basically, on a Wednesday morning, I take the Mastermind session and I cover quite a few things in Elite, but primarily, I guess, cardiovascular disease, insulin resistance, and diabetes and things like that. And then I move on to some other metabolic changes that can occur as we get older. So cardiovascular disease, the basics, what am I going to chat about this morning? So cardiovascular disease, what is it? It's essentially just a general term for conditions that affect the heart and blood vessels. Okay. And it's usually associated with the buildup of fatty deposits inside the arteries. And the kind of pathophysiology term for this, the medical term for this, is atherosclerosis. And the fatty plaques that build up are called atheroma, but I am more than happy just to call them fatty plaques. I never call them atheroma. And it's funny, when we chat to colleagues, we just call them fatty plaques. We don't call them atheroma either. But atheroma is the technical term, but fatty plaques, more than good. So essentially, when you've got cardiovascular disease, you get damage to the arteries, and this occurs all over the body, not just the heart. Lots of people just think it happens in the heart, or it's obvious in the heart, but it happens in the brain, heart, kidneys, and eyes. And essentially, cardiovascular disease is the main cause of death and disability in the UK. Okay. So that's the bad news. The good news is it's preventable. All right. Any questions? No. Okay. So I'm going to go into a little bit, just going to kind of divide cardiovascular disease up into different types. So the first one I would kind of break it down into would be coronary heart disease. All right. And your heart is essentially a large organ that has three big arteries wrapped around it. And we'll come back to this, and I'll show you some diagrams in the next few sessions. So essentially, your heart's a big muscle that's got three big arteries that supply it, because even though your heart pumps blood all the way around the rest of your body to keep every other organ happy, your heart is an organ and it needs to have oxygen and blood. So there is a flow of oxygen-rich blood that supplies the heart, and if those big arteries that supply the heart become blocked, or not even fully blocked, but just slightly blocked, and the blood flow is not as good, this puts increased strain in the heart. And has anybody any idea what happens when the heart's under strain, but it's not necessarily, it's getting some blood to it, but not as much as it needs possibly? There's a condition.
It gets bigger because it's working harder.
It can get bigger, yeah, because it's working harder. There's a symptom you get though called angina.
Angina.
Angina, yeah. Okay, so essentially, angina is the first kind of warning shot that there's an issue with the blood supply to your heart. All right, and that's basically indicating. And when you get angina, it can be what we call stable angina. So that would be essentially when you exercise. So you wouldn't get chest pain sitting watching telly or in bed. But if I asked you to climb up a flight of stairs or go on a walk up a hill, you might start to get some chest pain. And that's because your heart's working harder. And it's funny, I'm currently in Arran at the moment, an island of Scotland. And we climbed Goatfell yesterday. There was a group of 7 of us loaded with a cold. Great idea. Anyway, off we went, and it's not quite a Munro. We had to explain this to there's 3 kids, and we had to explain that it wasn't quite a Munro. And we bought the kids t-shirts when they came back down again, because it's 2,866 feet, and apparently a Munro is 3,000 feet. However, Goatfell's quite different because you start at sea level. There aren't a lot of Munros that you start at sea level. You know, they may be over 3,000 feet, but you start halfway up them. So I would argue we climbed a lot more than a Munro yesterday. But it was funny when we were going up, you're out of breath really easily. And the last, say, 10, 20% of going up Goatfell are big boulders, and it's literally just steps, and you can really, really feel it. the way down, you come down a lot more quickly, but you'd hardly feel your heart at all. And you're still working, you know, your legs are still carrying you, but the fact that you're going downhill, and it's essentially, I was explaining to them that your heart's just not having to work as hard at all, and it's actually quite phenomenal, just literally going up any gradient, and you'll feel that. And one of the things is when you're out walking, when you're doing your 10,000 steps, 10,000 steps in the flats, great. But if you just want to do a little bit more exercise, you don't have to run. You don't have to run marathons. You don't have to, you know, get on a bike or do anything like that. All you have to do is go on a slight incline, and you'll feel yourselves a slight incline, and your heart works harder. And it doesn't take very much. Going up a flight of stairs, your heart works harder. It just has to do more. And when you've got issues with your fatty plaques in your arteries, and there's a decrease in the blood flow in your arteries supplying your heart, and therefore a decrease in oxygen being provided to your heart, that's when you can get into trouble. So when you start straining your heart, the first symptoms you'll have are called angina. If there's a sudden blockage, this is obviously a heart attack. And if you've had a heart attack or problems, this can obviously lead to further issues, including heart failure. Okay. So that's what goes on in your heart. In your head, it's the same process, but we just call it something differently. So when you get the blood supply blocked off into your head, it's a stroke. Okay, so it's an ischemic stroke. There are two different types of stroke. There's ischemic strokes and hemorrhagic strokes. A hemorrhagic stroke is when you have a bleed, but the majority of strokes, about 80% of strokes, will be ischemic, and that means ischemic just means a lack of oxygen. So when there's a blockage, there's less blood, less oxygen, and that again can lead to brain damage, which can be irreversible and possibly death if you have a big enough stroke. And then you can have a prelude to a stroke as well. So you've got angina, that kind of gives you a warning shot to possibly going on to have a heart attack. Can anybody tell me what the thing is that you can have that would give you a little warning that you may be going to have a stroke?
TIA.
A TIA, excellent, Carol, thanks. So TIA is basically transient ischemic attack, or a mini stroke. And it's essentially like a stroke, but the difference in how you tell someone they've had a TIA versus a stroke is the blood flow is only temporarily disrupted, and the things that happen, whether you have a weakness or slurred speech, everything resolves within 24 hours. Okay, if it doesn't resolve within 24 hours, you've had a full-blown stroke. If it resolves within 24 hours, it can be said to be a TIA, or a transient ischemic attack. So the TIA to a stroke is what angina is to your heart attack. Okay, they're both little kind of warning shots, which I think is quite good, because a warning shot is good, because the alternative to your warning shot is basically walking along, having a heart attack and falling over. So if you get angina, yes, it's not great, but at least you're getting a little warning shot saying something's not great here, let's get this seen to, and then you can do something about it. So that's your heart and your head we've covered. We're now going to move down to your legs. So there's when you have problems with atherosclerosis and atheroma in your legs, it's called peripheral, either peripheral vascular disease or peripheral arterial disease. And it's the same thing, just in a different part of your body. Okay. And this presents by having like a kind of dull cramping leg pain, usually starts in your calves. All right. And it's worse on walking. So again, you'll get a warning shot. You don't go from having completely normal, great legs to having full-blown blockages in your arteries in your legs. You will go through stages. And this kind of dull cramping that you get when you walk in the back of your calves is known as intermittent claudication. And it's intermittent because you'll, again, fine sitting watching telly, you'll be okay, but you go out and walk, and to begin with, it might happen when you're walking up hills, and then it progresses. And the vascular surgeons will often say, how far can you walk? And you'll say, well, I used to be able to walk 3 miles. I can only walk a mile now. I can only walk 500 yards. I can only walk 100 yards, and my legs get sore, and I have to stop. And you stop and rest, and you're not working your muscles as hard. The more blood and oxygen gets to the muscles, they're not sore. You start to walk off again, and then you'll get a certain distance. And they can tell pretty much how severe the peripheral vascular disease is and how far you can walk. Okay, you'll further on, you'll get other symptoms. So you may lose hair in your legs and your feet, and you may get numbness and weakness in your legs, and then you may get persistent ulcers. And that's essentially due to just because you've got a really poor blood supply in your legs. Okay, and again, if you get a cut or something, it would be more difficult to heal. Okay, so
is that when they put stents in?
Yeah, they can put stents in, Daryl, and they can do that to your big artery, the aorta, which branches off your heart and then comes down the middle of your body. It bifurcates in your pelvis to your femoral arteries, and you get two big femoral arteries, one in each leg, and then they branch off to other arteries. But yeah, they can put stents in your legs, and they can put stents in your heart as well. So that's one of the big treatments. Previously, 30, 40 years ago, what they would do if you had atheroma, people would get what they would call a coronary artery bypass graft. So essentially, and it's a bypass, it's literally like a bypass in a motorway. They would take a vein from your leg and they would bypass round, they would sew it, they would open your chest up, and the surgeons would sew it from point A to point C, missing the blockage in between. But they don't do that as often now, because if you have an area with atheroma, they will put a stent in. Do you know what a stent is, Daryl?
Well, my daughter's a radiographer, so she's always x-raying to make sure they put it in the right place. But it's just a thing that opens up and it balloons. It's got a balloon on it or something.
Yep. So basically,
they put it in through the groin or the wrist or something like that, and then
excellent. We'll get Daryl to do a session on stents. Sounds fab. So a stent to me, and I'm sure any cardiologist or vascular surgeon would just weep if they heard me saying this. Stents, do you know the bit of a pen that you're sitting fiddling with in your group meeting, and next thing the top of the pen flies off and the spring bounces to the other side of the room, and you're really embarrassed for two reasons. One, because you've obviously created noise, and two, you now don't have a pen to make any notes with. So this coiled spring bit, that's like a stent. Now that is really crude. I'm sure they are far more delicate and fine than that, but that's essentially what I think of as a stent. And yes, you're right about the balloon. So what happens is the stent is put over it like a guide wire or a line that has a balloon in it, and you feed that. You either get it up through your groin, through the artery in your groin, or in your wrist, depending what your anatomy's like. Or I think the groin's used, well, no, the wrist's probably used quite a bit as well. So it's fed up round into your heart, and they slide this kind of coiled thing into where the blockage is, and then they put air into the balloon blows up, and the stent will expand, and the stent will squash the plaque and open up the artery again. And they've got really fancy stents now because they've got drug-eluting stents. So the stent will actually elute drugs that keep the blood thin. So there are drugs you will go on if you get a stent. So you will be, originally the drug that everybody would have been put on was aspirin, and then they've got another one called clopidogrel, and it interferes with the clotting cascade. So it blocks the clotting cascade happening in your blood. So and if that drug is eluted from the stent, it means there's less likely a clot will form in that area of your body compared to anywhere else. Because you don't want to completely stop your clotting cascade, because you need to clot if you bleed from other places. Okay, so yeah, that's what stents are, and they can use those in your legs as well. Okay, and that, I guess that must be one of the big things that's really revolutionized heart disease, because before, cranking open someone's chest and doing a bypass is a really, really big surgery, whereas they can put stents in relatively quickly. They can also put 2 or 3 stents in at a time. So if you've got what they would call multi-vessel disease, they can put stents in 2 or 3 of the arteries in your heart in the one go. What they can't do, and I think that you still get people who get heart surgery, coronary artery bypass grafts, and I think that happens more commonly if you've got diffuse disease. So that means you've got diseased all along the artery, it's not just in one particular area, because you can't stent the whole artery. That doesn't work. Okay, or it's very difficult to do. All right, so we've got coronary artery disease or coronary vascular disease. We've got strokes, TIAs, and then we've got peripheral vascular disease. And the last one, we've got aortic disease. And that essentially just affects the aorta, which is the huge artery that comes off your heart that all your blood's pumped into before it goes around the body. And a common aortic disease is aortic aneurysm. You may have heard of people who've had problems with aortic aneurysm, and that's essentially just a weakening of the vessel wall. And it means it bulges outwards, and it's usually asymptomatic. The problem with these are you don't have any issues at all because the blood flows through it fine. The problem is when they pop. Okay, because obviously it's the biggest artery in your body, and if they burst, it's life-threatening. Okay, so All right, so those are that's kind of the different types of cardiovascular disease. Affects your heart, affects your head. So the three main ones, I guess, are your heart attacks, your strokes, and your peripheral vascular disease. All the same process. It's the same process. It's just happening in different parts of your body. And if you've got problems with peripheral vascular disease, you've had a heart attack and a stroke, we would often refer to you as an arteriopath because we know it's having big issues throughout your body. Okay. So we're now going to move on to the causes of cardiovascular disease. The exact cause is unclear. All right, like most things in medicine, I would suggest. But risk factors are important. We do know there are lots of risk factors. And the more risk factors you have, the more likely you are to have issues. Okay, so I like to break my risk factors down into two different groups. First group, non-modifiable, and the second group, modifiable. So non-modifiable we're going to discuss, but the thing is non-modifiable, we can't do anything about them. All right, so job done. You can't do anything about it, but we'll discuss them anyway, because it's still important when a doctor is taking a history to know about the non-modifiable risk factors, because it still can increase your risk. All right, so can anybody think of anything that increases your risk of cardiovascular disease that's non-modifiable?
The age.
Yes, and that's one that really affects. We have, and I'll chat about these later on when I'm talking about cholesterol and cardiovascular disease over the next few weeks. Age is a huge one because it really drives, when we use mathematical models to predict your risk, really influenced by age, because you're more likely to have a heart attack at 80 than 20. You just are, okay, because you're older. I'm not saying somebody at 20 can't have a heart attack, especially if they're using cocaine. But what I am saying is you're far more likely to have a heart attack at 80 than 20. The same way you're more likely to have a lot of cancers when you're 70 than when you're 20. Again, you can have cancer when you're 20, but it's less likely. So age is a huge risk factor, and the risk scores account for that. So age, excellent, Linda. Anything else?
Genetics.
Yep. You can choose your friends, can't choose your family. Your genes are your genes, okay? And one of the genetic diseases that I work with in the lipid clinic is familial hypercholesterolemia. Okay, and we'll do about that at some stage as well. So FH, familial is just in the family, and hypercholesterolemia is high cholesterol, and it's a dominant trait. So you only need one faulty gene from one of your parents, and that results in a high cholesterol, and if it's not treated, results in cardiovascular disease about a decade earlier than the normal population. Okay. Okay, so age and genetics. Sex, yep. So that's important as well. So before the menopause, men are about 10 years ahead of us in terms of heart disease. And this is one of the really important things they found out over the last 10, 15 years. They kind of thought heart disease was a man's game, and it's not. And particularly once we pass through the menopause around the age of 50, because we bypass men, and I'll do about that when we do a session on the menopause. Yep, so sex is important. And there's one more. Ethnicity. Okay, so essentially we know some of the ethnic minorities. So for example, the Asian population, etc., will have more issues with insulin resistance and heart disease at a lower BMI, okay, than the Caucasian population. All right. Okay, so those are the non-modifiable ones. In terms of, sorry, a little bit more about ethnicity. Yeah, cardiovascular disease is more common in people of South Asian, African, and Caribbean background. They are more likely to, as I said, have increased insulin resistance, type 2 diabetes at a lower BMI. So they can have a problem with their lipids when their BMI is 25, 26. Okay, whereas most of the Caucasian population I would treat would, their BMI would need to be possibly nearer 30. Okay, and the NHS BMI calculator I use the healthy BMI 20 to 25, and don't worry, we'll do about the body mass index and stuff. Sorry, apologies, body mass index, I hadn't said that, is based on a Caucasian population. However, it does take into account the ethnicities now, so you can put in the person's ethnic origin and it will account for that in terms of risk. Okay. All right. Okay. In terms of your genetics, it is important. Even though it's non-modifiable, it is an important thing for you to chat to your health physician about your GP if you're, getting reviewed for cardiovascular disease or any disease. You should always tell them about a family history, and a family history in cardiovascular disease would be important in terms of a first-degree relative having a heart attack or a stroke less than the age of 60, and a second-degree relative less than the age of 50. Okay, so first-degree relative, by that I mean your mum, dad, or your siblings, and a second-degree relative would be your grandparents. Okay, so those are all important when you're chatting to your doctor. Okay, right, we're going to cover modifiable, and this is where it gets interesting, and this is where we can do things. So I have 1, 2, 3, 4, 5, 6, 7, 8 modifiable risk factors for heart disease.
Overweight.
Yep, excellent. Overweight. Yep, that's a big one.
Smoking.
Yep, smoking. Yep.
Alcohol intake.
Yes, alcohol, smoking, weight.
Cholesterol.
Yep, high cholesterol, good.
Sedentary lifestyle, exercise.
Inactivity, sedentary lifestyle, that's a very important one. Yep, they're all really important, actually. I don't think there's any more important than others. And they're all linked, if I'm being honest with myself, I think, yeah.
Just diet in general.
Yep, nutrition, diet, very important. I've got 2 more.
Exercise.
Yep, so exercise, yep. Blood pressure, okay. That's a really, really big one in terms of heart attacks and strokes. And we'll come back to why that is in a wee minute. And the other one I have is diabetes, okay. In particular, type 2 diabetes. Well, I suppose type 1 as well actually increases your risk. So yes, so diabetes, and don't worry, we'll cover the difference between type 1 and type 2 diabetes in the next few weeks. So diabetes increases your cardiovascular risk. All right, so those are the 8. So let's chat a little bit about blood pressure. So blood pressure, the medical term for that is hypertension. Okay, so if your GP is chatting about blood pressure, they may chat about hypertension. Okay, and it's one of the top risk factors for cardiovascular disease. And essentially why is because if it's high, it can damage your blood vessels. So, and we're going to do a session about blood pressure and stroke in the next few weeks. So essentially, if you can think of the fatty plaques, and if you give me 2 seconds, I'm actually going to, right, this is quite exciting. I'm not at work, and when I'm at work, I have 2 screens. Okay, so this will be good. If I lose you all, apologies, do come back into the room. I don't think I will, don't panic. Okay, I just want to see if I can show you something. All right. But I need to go into my documents. So essentially, I'm going to show you some pictures of, I don't usually do this at this stage, but we'll do it because I'll go back over these. But if you can just bear with me a little minute. Of course, I'm not at work, so I now have to get into my work system so that I can look at my general folder. Everybody still with me?
Yeah.
Yeah.
Lost anybody yet? Right, apologies, but I'm getting there. Okay, so let's see if right, here we go. I'm going to show you a couple of pictures. I've got a couple of pictures of plaques, okay, and this will explain why blood pressure is quite important. Okay. Okay, right. So now let me see if where is the I share screen. Sorry, it's the big red green one. You think it would be quite obvious, wouldn't you? Right, okay, here we go. So apologies. Right, can you see that?
Yes.
Yeah, right. So this is quite a simple cartoon that just shows you what's happening and why blood pressure is important. So healthy artery. If you can imagine your arteries are like hose pipes, yeah? I like to make things very simple. So it's like a hose pipe. So that's cut across it. And that's cut, this is longitudinally, okay? So this is the little red things are blood cells. So healthy artery, these are your arterial walls and the blood cells are meandering along here, carrying oxygen. Everybody's happy. This is the kind of atheroma, the plaque formation that I was chatting about earlier. So this is when it starts, okay? And you can get plaque formation at both sides of your artery. So here you can see the blood has to travel up and over this. So the flow is becoming more turbulent. And then you've got plaques on both sides, and it's actually really difficult for the blood and therefore the oxygen to get through here, okay? But what happens here is if your blood pressure is high, this flow gets more and more turbulent, okay? So if you've got high blood pressure, you've got more chances of these plaques rupturing because the blood flow flowing over this isn't smooth anymore because it's getting forced at a higher pressure. Okay, so that's why blood pressure is really important when it comes to cardiovascular disease. All right. I'm just going to leave this up actually because lots of the things affect this. So smoking, how does smoking affect? It's a really important risk factor as well. So essentially, and we'll do a session on smoking, smoking accelerates the growth of these fatty plaques. Okay, so that's why smoking's bad. And it's funny because smoking, you know, I was going to say we got the message across that smoking's bad in terms of your lungs, but looking at the vaping craze at the moment, you'd wonder whether we did get the message across that smoking's bad for your lungs because we seem to be making the same mistakes we made 40 or 50 years ago again. But essentially, in terms of smoking, smoking is bad for your lungs, but smoking accelerates heart disease and having a stroke because smoking accelerates the formation of these fatty plaques. And don't worry, we'll do a session on smoking. High cholesterol, we chatted about cholesterol being important in terms of one of your risk factors. And
And do we all have blood vessels that look like the second one? Is that like I heard the Western diet?
yeah, okay. So essentially, sorry, give me 2 seconds. Apologies. Yeah, we probably do. All right. The original papers showed that these are actually in the and particularly in Western society are laid down really early. These happen in our early 20s. Okay. Which is pretty grim, isn't it? Or I find quite disturbing. So yes, yeah, I would doubt very much any of us have got arteries like this all over the place. Okay, but the good news is I climbed up a mountain yesterday and didn't get angina. So I'm figuring I do have these, but not in an extent that they're stopping the blood getting to my heart. Okay.
Can they be reversed, or is it once you've got them, you've got them?
That's another excellent question. So if you'd asked me that question, well, even 12 months ago, I think when I was chatting this, I said, no, they couldn't be reversed. There are quite a few studies coming up now showing that the the medications we use can reverse them. There are quite a few different medications we use to lower your cholesterol now. The primary ones, the ones you probably have heard of, are statins. And the studies now show that if you're treated very aggressively with statin therapy, in particular after, I think most of the studies have been done in people who've had an event, okay? So if you've had an event, whether it's excuse me, a heart attack or a stroke, and they put you on a statin, they can get the plaques to regress. Excuse me, whether they disappear altogether, I'm not convinced, but they can get them to regress. Okay. But I don't think, I'm not on statins, but if I was on statins and I have some of these, I'm not too sure. I don't think you would ever get them to disappear. We don't have a kind of domestos that we can take that just, cleans your arteries. So I just like thinking of things rather simply. So basically, yeah, blood pressure makes this more likely to rupture, makes the blood flow more turbulent. Smoking increases your fatty plaques. Your cholesterol, so high cholesterol is important in terms of heart disease or vascular disease in your head, heart, legs, because these fatty plaques are LDL cholesterol. And again, don't worry, we're going to do a session on cholesterol, and cholesterol is broken down into two main parts, HDL and LDL, LDL being low density, and I'll explain that in a lot more detail when we do the session on cholesterol. But essentially, this is the LDL. The LDL forms the fatty plaques. Okay, the LDL is taken up by some of your blood cells called macrophages. They become oxidized, which is accelerated by smoking, to form foam cells. The foam cells are laid down and they form the fatty plaques. Okay, so one of the other risk factors we chatted about was diabetes. So how does diabetes feed into all of this? Well, so diabetes is essentially, and again, we're going to do a session on diabetes. We'll do two sessions. We'll do one telling you a little bit about type 1 diabetes versus type 2, and then we'll do another session on the kind of complications of diabetes, acute and non-acute. But essentially, we know diabetes, it means you've got too much sugar in your blood. Okay, you're not controlling it. Well, type 2 diabetes, you're insulin resistant. Type 1 diabetes, you don't have, your pancreas can't produce insulin, so your blood glucose levels are too high. And having too high blood glucose damages your vessel walls, okay? And they're more likely to become narrow. And type 2 diabetics, insulin resistance results from being overweight. And when you're overweight, this puts pressure in this whole system. If you're overweight, your heart has to pump blood through every single vessel in your body, including all the adipose tissue, the fat tissue that has to have a supply of blood as well. And that's one of the first things you'll notice if you lose weight. If you're at a certain weight. No, well, the really good example of this is when Alex asks you to put whatever weight you've lost on a backpack and go up a flight of stairs. Okay, so is it harder or easier? It's a lot harder, isn't it? And that's because your heart's working so much harder to get that weight up the stairs. And I think that's one of the most poignant exercises you can do. If you've lost 5 kilograms, 10 kilograms, 15 kilograms, some of the ladies have lost like 5 or 6 stones. Can you imagine strapping 5 or 6 stones in your back and going for a walk? It would be absolutely immense. And that's what you've carried around. So it just shows you how much harder your heart has to work. Okay, so, and type 2 diabetes is often tied in with being overweight. Okay, so how does inactivity play into all of this? One of the other modifiable risk factors. If you do little or no exercise, your blood pressure will be higher. It affects your cholesterol, so your cholesterol will be higher, and your weight is more likely to be higher. Okay, and they all increase your risk of cardiovascular disease. And if you exercise regularly, you're working your heart. It's a muscle like any other muscle. So if you exercise regularly, you're working your heart. And also if you have a good nutrition, it's easier to maintain a healthy weight. And the overweight is really important in terms of cardiovascular disease because two things. One, three things, I guess. I've just told you that the heavier you are, the more your heart has to work. Okay. Increased weight increases your blood pressure because we know if you lose weight, you will decrease your blood pressure. and increased weight increases your risk of type 2 diabetes or insulin resistance, both of which put your risk of heart disease up. Okay, so weight just increases your overall risk of heart disease. And they're all tied in. You don't really take any of them in isolation. If you're overweight, you're more likely to be less active. You're also more likely to have higher cholesterol, and you're more likely to have a poorer diet, I would suggest. Okay, so how's diet related to heart disease? So if you've got a diet, which I would say there's two things. So what kind of diet do you think increases your risk of heart disease? There's an obvious one, and then there's kind of a less obvious one, I would suggest.
High fat.
High fat, yeah. So, and that's one of the labs I do. Labs with the medical students, and in first year I take them for a blood. It's a blood fat lab and heart disease, and it's essentially we have patient A and patient B, and patient A has a diet high in saturated fat, and we measure their cholesterol, etc. So high in saturated fat can affect your cholesterol levels. High in saturated fat will affect your weight at the end of the day, won't it? Excuse me. The other one is refined carbohydrates. So essentially, and this is where I think there's the big misnomer about carbohydrates. Carbohydrates are not bad because there are different types of carbohydrate. And there's probably carbohydrate in every, I can't think of any fruit or veg you can have that doesn't have carbohydrate in it. But fruit and veg are very good for you, but they've all got carbohydrate in them. But what also has carbohydrate in them is refined carbohydrate. So your donut is not the same as your broccoli or your carrots or your sweet potato. There is a huge difference there, but they're both carbohydrate. And that's the message I think we do not get across well, or if at all. We really, really do miss the point with that for whatever reason. And I think we did quite well 20 or 30 years ago. We got off the frying thing. We got the idea that high saturated fats were bad for us. We got the idea that frying was bad for us. And as a public health thing, that worked quite well. But we now jumped on the carbs bandwagon, but it's everything carbohydrate is bad. And I don't agree with that. I think there's different types of carbohydrate. What happens with your refined carbohydrates is we convert them to fat, because essentially when we take refined carbohydrate and we break them down really quickly, it produces glucose, okay, which is the carbohydrate we use to fuel ourselves. When we replace our glucose in our muscles and our liver, we store it. We can store it as glycogen. We replace our glucose stores that are required for energy straight away. But then when we've got enough of that, we make a molecule called glycogen, which is a big storage molecule. But we can only store so much of that because there's a lot of water in glycogen. It's a really bulky molecule. So once we've replete the glucose in our muscles and the glycogen in our muscles and the glucose in our liver and the glycogen in our liver, we then convert any excess carbohydrate to triglycerides, which are stored as fat. All right, and that's a really good energy source, and it's a really good way to store energy when you've been running around, bat a bear over the head, eat it, and then don't eat for the next 4 weeks. That's what we should do. If we've got excess carbohydrate, we should store it. So when we need to, or we store it as fat, and then we need to break it down. The problem arises when you've got a sedentary lifestyle and a lot of refined carbohydrates. So you're not using your glucose, so we store a lot as triglycerides. Excuse me. So diet's important. We want a diet that's not got a lot of saturated fat in it, and we won't have a lot of saturated fat in our diet. Why will we not have a lot of saturated fat in our diet in TSD?
There's no pies and pastries, that's why.
But yeah, right. No pies and pastries, correct. And that's what I think of when I think of saturated fat, especially being in the west of Scotland. But what did you notice when you first started out in TSD, when you were probably given a calorie intake of about, excuse me, 1500
less calories. Calorie deficit.
Excuse me. Apologies, I should have probably cancelled this morning. But onwards and upwards. Right, yeah, so you don't get a lot of bang for your buck, do you? You can eat a croissant if you want, but you've really, gone into your your calorie budget for the day, and you won't feel, I wouldn't feel satiated. And the biggest thing, it's quite funny, some of the people who went through TSD with me to begin with, the big realization I had was cheddar cheese. So I went and cut a block of 20 grams of cheddar cheese and was appalled at the size of a block of 20 grams of cheddar cheese. And it was about 80 or 100 calories. And I'm thinking, that's literally nothing. That's not going to fill me up. You know, it's not going to do anything. So I don't eat a lot of cheese now, essentially. And I wasn't, I like cheese, don't get me wrong, but I just don't eat a lot of it because it will not fill me up. It will not satiate me. It's nice, don't get me wrong, but I just don't get a lot of calories. And that's because there's fat in it. And we know that, for every gram of fat, it's 9 kilocalories, isn't it? Whereas for every gram of carbohydrate or protein, it's 4 kilocalories. So I can have twice as much carbohydrate or protein as I can fat for the same number of calories. And it's funny, and that's kind of dictated my diet, kind of subconsciously, I guess. Okay, so the other risk factor was alcohol. So excess alcohol, what does it do? It increases your cholesterol and your triglycerides. Alcohol affects your liver. And don't worry, we'll do a session in this, but we'll chat about lipid metabolism, and that's all regulated by your liver, and your liver's affected by alcohol. Alcohol in excess can elevate your blood pressure. And also, alcohol's got calories in it. So how many calories are in a gram of alcohol?
9, 7.
That's fat. 7. Yes, 7. Okay, so it's in between carbohydrate and fat. Okay, so there's quite a lot of calories in alcohol, and you'll know that as well because you'll have taken that into your when you were counting calories to begin with. Okay, so how do we prevent cardiovascular disease? And I've written down here, healthy lifestyle, as simple as that, exclamation mark, exclamation mark. All right, so it's as simple and as complicated as that, I would suggest. So what's the big thing? My big thing would be my first port of call for any of my patients, even before I would tackle weight, is smoking. All right, and we'll come back to this when I do the session on smoking. All right, smoking is really a no-no when it comes to cardiovascular disease, and I'll show you a graph when we're chatting about smoking that shows you the difference, someone being overweight versus someone smoking in terms of heart disease versus the natural progression of heart disease. So I think it's probably the most beneficial intervention, bar none. Okay, stopping smoking. Smoking is a huge issue in terms of the buildup of their atherosclerotic plaques. Okay. Next on my list would be a balanced diet. Okay. And I could say decrease saturated fat, decrease your salt, decrease your sugar, etc., etc. One of the easy ways to think of this, I think of, is brown, not white. So does anybody know what I mean by that?
Unrefined rather than refined, so brown rice as opposed to white rice.
So, yeah, excellent, Marella. And also, and eat the rainbow. So that kind of covers your fruit and veg. So if you eat the rainbow and you stick to brown, not white, you will be going a huge way to having a balanced diet. Okay. Exercise regularly. So again, the NHS suggests 150 minutes of brisk walking a week, but 10,000 steps, yes. And obviously resistance training that we do is very important. And I think we're coming more around to the idea of that. The NHS weight loss app will suggest about doing weights and things like that, because again, apart from providing strength for your muscles and your bones as you get older, we know that if you build up muscle, you can have a few more calories, so you don't have to reduce your calories further to lose more weight. So that's really important. And weight loss, obviously looking at your diet, looking at exercise together can result in weight loss, and that will decrease your body mass index, but possibly more importantly, your waist circumference. And we'll chat about that again in more detail when we talk about heart disease, when we chat about your waist circumference. Okay. Cut down alcohol. What's the recommended intake of alcohol a week for adults in the UK?
Oh.
14 units.
14?
Yeah, 14 units. It used to be 21 for men and 14 for females, but it's 14 for both now. And knowing your units is important as well. And we'll come back to that because we'll do a session on alcohol. All right. It's all very well saying 14 units, but if you don't know what a unit is and whatever you're drinking, it doesn't really work, does it? And you'd be surprised. So, and medication. Okay, medication is important to decrease your risk. If you're at high risk, if you're put on a medication, for the most two common ones would be blood pressure and cholesterol, please listen to your family physician. Okay, and you shouldn't stop medications without discussing them with your family physician. If you lose weight, the chances are you will be able to decrease your blood pressure medication or come off it, but that should be guided by your GP. Okay, blood pressure is really important in terms of stroke and heart attacks. Okay.
But with blood pressure, Caroline, if when you go to the GP you have the white doctor syndrome, how can you ever prove that you've got a lower blood pressure because you've lost weight?
It's an excellent question. The best way to do that is to get your own monitor. Okay, and I will do a session on blood pressure, but I think it's the British Hypertension Society. If you go to online and go to the British Hypertension Society, they will give you, because you can buy, you go onto Google or Amazon and you can Google blood pressure monitors and hundreds of them will come up. But I think the British Hypertension Society will give you an idea of which make to get. Okay, and the best way to do your blood pressure, and I suggest this to patients all the time, there was a paper out in this quite a few years ago, is to do it at home. The hospital can organise for you to have a 24-hour blood pressure monitor done, but that's quite, I would say,
quite invasive because it wakes you up all the time and it
exactly
pinches you as well. I find.
Yeah, and it's not normal, is it, to get your blood pressure cuff blowing up at 3 o'clock in the morning when you're trying to sleep? I would suggest. So what you want to do, get a blood pressure monitor, and you take your blood pressure measurements 4 times a day. So twice between 6 a.m. in the morning and 9 a.m. in the morning, and then twice between 6 p.m. at night and 9 p.m. at night for 7 days. Disregard the first day's results. So that's disregard the first 4 days' results because everybody gets a little bit excited doing it. And then you've got 6 days results, 4 results each day. So that's 24 results, and bring those to your GP.
Okay, thank you.
Okay, so white coat hypertension that Daryl's chatting about. Somebody was in my clinic last week and I said to them, I said, your blood pressure is quite high today. And they said, yeah. And they've been doing theirs at home. And they said, yeah, it's fine at home. And they said, why is that? Why is it high? And I said, oh, because you don't like coming to see us. I make a bit of a joke about it and say it's fine. I don't take it personally. But yeah, white coat hypertension is always a thing. And the other thing I have, it's not even white coat hypertension. It's usually people can't get parked when they're coming to the hospital. So by the time, they've either got stuck in traffic, come round the corner in 2 wheels, and then when they get to the hospital, they can't get parked, and then they've had to run to the clinic. So everybody's usually in quite a sweaty mess, and they get sat down and the nurse says, right, let's do your blood pressure. So often if it's quite high in clinic, I'll say to them, right, at the end, go and sit for 10 minutes, we'll take your blood pressure again, and then I'll have a look at that before they leave. If somebody says to me, oh, it's always high when I go to the GPs or come to you guys kind of thing, I'll say, right, if you got a monitor at home, they'll say yes. And I'll say, right, go home, do it when you go home today. And if it's back down, that's fine. If it's not, call your GP and make sure you get that assessed again. Okay. But that's probably the best way to do it. Okay. Okay, so I think that's pretty much us. Has anybody got any questions?
No, you just scared me to death. You've just described my husband, really. Well, apart from the fact that he doesn't smoke, he's got all the other risk factors. And it's trying to convince him to change. It's not easy, is it?
No, it's not. It's very difficult.
He likes his lifestyle. He's on medication, so his blood pressure's controlled. He's on statins, so hopefully that's under control. But you can't live your life like that. Ideally, I would like him to get off all of that and reduce his weight, reduce his risk. He's got first degree history with his family as well. His sister died of a bleed on the brain. His mother's had heart attacks. His dad died of heart attack. It's really scary, isn't it?
It is, and the problem, what I try and emphasize in clinic is, because they come to me and I put people on statins all the time. You can take the blood pressure medication and you can take the statin, but I'm not alleviating all the risk. There are 6, 7, 8 risk factors. We can only use medication for a couple of the risk factors. Okay, so you're not, you've decreased your risk a bit, but not fully. I had a case the other week that a cardiologist had referred someone to me, and they're trying to get their LDL down lower, and they're on a lot of medication already. And I read the full review, I went into their electronic patient record, and the gentleman's BMI was 39, and their HbA1c, which is a marker of diabetes, and don't worry, we'll come back to that, wasn't well controlled. And I'm like, you're trying to push the LDL down with medication lower and lower and lower. And I'm like, the bigger picture here, the guy's overweight and his diabetes isn't well controlled. So, just they're focusing in one bit. And I'm like, there's the overall picture. They're still going to run into problems. So it's difficult, Marella. And you can take a horse to water, I guess, but you can't.
Well, yeah. I mean, I cook healthy meals. I mean, I've been doing it for years, cooking healthy meals. But he comes home from work with a great big bar of chocolate, and we'll eat it all in one sitting.
I know, it's tough.
Yeah.
Send it up to Caroline's clinic, Mirelle.
Well, yeah, he needs to go somewhere. But he's not got his listening ears on at the moment, if you know what I mean.
Yeah, no, I know.
I mean, you can see that.
I know where you're coming from.
Yeah.
Yep, no, very much so. I know where you're coming from. So,
we all know this. I mean, it's like, why do people continue to smoke when we know how dangerous it is? And yet there's more and more kids still taking it up, isn't there?
No, I know, and the vaping issue is just a disaster as well.
Yeah.
It really is. Okay. Right. Lovely to speak to you this morning. Okay, have a good week. And I shall catch up with you next week. Hopefully I will not be full of the lurgy next week. Apologies for the interruptions this morning.
Wish you a speedy recovery.
Oh, right. Thank you very much. I'm actually off this week. I'm in, well, I was going to say sunny iron, but it's blowing a hoolie here. And of course you always get the lurgy when you're not at work. All right. Okay, well, look, have a lovely week. And yeah, I shall catch up with you next week. All right. Take care, ladies.
Yeah, bye.
Bye.
Thank you. Bye. Bye.